Just gonna wait a few more seconds before 6 and then we'll get going. Hello to everyone that's out there already. Before everyone else comes on, those of you that are already logged on, if you've got any questions from the last two sessions that we've done, if you want to pop any questions in the chat box, and I'll try to sort those as we go through. Hi Cassie, how are you? Yeah, there's a are we at 6 yet? Hey Al, how you doing, mate? Okay, we're at 6, so we'll get going. And welcome to the last session for this week. It's been a really weird week. I found that, I'm very good. Thanks, Cassie. Yeah, not too bad at all. Better than Boris at the moment, by the sounds of it. It's been a bit of a strange week. And I think doing these has actually given me a bit of purpose this week. So that's really, it's been quite good. I've had to tweak these presentations because normally we do them face to face, and we do loads of group work with them as well too. So the tasks that we've given you over the last week, that's what we would normally do in a session and kind of talk through it. I just want to pop this book up. So everything that we've covered on these sessions is from the kind of the Civ part of it can be found in this book. So it's, you should have a little red circle under the offers bit. So this is just pointing you towards Amazon. It's a book called Differential Diagnosis for Physical Therapists, and if you've not really covered the kind of stuff that we've done on these webinars before, then it's a really good starting point. So hopefully all of you will know who I am by now. If you are just joining us on this last one, then my name is Mike, and we teach therapists, and we are also therapists. So we run a clinic and we also teach. We've got 3 training schools over the country. We've got one in Southport near Liverpool, one in Leeds, and our one in Birmingham as well. So we practice what we preach. Everything that we teach on the courses we use with patients. So we try. I think it's best of both worlds, really, because we have to keep up to date with the latest research, and but then we're also trying to implement that research with real people, and sometimes that the research sounds great, but sometimes it doesn't work in real life. So we try and find ways that we can make it work, and that's then what we teach you guys. So hopefully you find it useful. This is what we've done so far. This session is probably not going to be a really long session. I was just saying before some of you guys logged on. If you've got any questions from the previous 2 sessions that we've done, if you want to pop that in the chat box, because we'll probably have a little bit more time for questions today. I'm imagining today's session will be no more than 20 minutes, so it's just going to be a quick kind of short, sharp finish off of everything we've been covering in the week. So what we've done so far, we've looked at a case history and a lady called Liz, and we picked out some key points from her case history. Then we started to create a sieve, and we tried to sift through all of the information that we got from Liz's case history, and then we then had to justify our clinical impression, so what we thought might be going on with her. And you don't depending on your qualification, you shouldn't be diagnosing anyway, but it's sometimes it's hard to have a diagnosis, and you can't actually do it without having them be referred. So you can have an idea of what is going on, but there could, like in the history with Liz, there was loads of things. So we need further investigation to find out exactly what's happened or happening with some of our patients. So the plan over the week was first session introduction to the case. So we did that. Then we had a look at planning objective assessments. So we're kind of introduced that, and we're going to go into a little bit more detail about that today. And then a plan. What do we do? Do we treat this lady or do we refer her? What's the plan for her? So we've had some really good suggestions on the Facebook group. Some people have had a good go at things, and I've had some private messages as well, which has been really good. So I really want everybody to give it a go, even if you haven't got a clue. Because that's the whole point, and because you're not meant to know everything. I don't know everything, and I would need to research things as well. So it's I think it's good to get you thinking whilst things are the way they are at the moment. So these are the key points from the sieve. So I've just kind of picked up a couple of things. Bear with me a second. Just got a question. Okay, cool. So I've had a message there from Alex. So in the differential diagnosis book or anywhere else, where can you look at a list of symptoms and then find whatever pathologies or diagnosis these could be linked to? The differential diagnosis book, the way that's laid out is laid out by body areas and body systems. So, for example, with Liz, I mean, she one of the key things with her, she had pain in the upper right quadrant. So the upper right quadrant of the abdomen is where your liver is. So what you can then do is have a look at that section of the differential diagnosis book for pain in the upper right quadrant, and it will come up with a list of differentials. There are some apps. Bear with me a second. Okay, I've got one here. Hopefully, hopefully be able to see this on the screen there. So this is a differential diagnosis app. It's called Common DDX. So DDX is differential diagnosis, and it's I think it's free. I don't remember paying for it, but it's an app on the iPhone. I don't know whether it's whether there are any other apps on Android as well. But yeah, if you have a look for differential diagnosis applications as well, there's also a really good app. Let me just get you this one. It's called MSD Pro. So it's that one there. It's the Merck manual. This one does cost, I think it's about 25 quid. But what you can do is you can search for things via body area or symptoms. So you type in a symptom and it will tell you all the things that it could possibly be. So that's a good one to get. I think what you've got to be mindful of as well is obviously the case history that we had here. It was quite severe. The likelihood of that ever happening in your clinic is very low. The kind of things that are wrong with these people on these OSCEs are very, very unusual, and it's like 0.1% of the population that may have these problems. Most people, like Liz in the case history, will just have a sore shoulder and they won't have anything else wrong with them. But I think the idea with these is that if someone does have a sore shoulder, then you then start to ask questions about their digestion, and you have it as a question in your case history, so that you can rule it or make it less likely rather than rule it out. You always want to have it there in the back of your mind, but it moves down the ladder. So yeah, if someone comes in with right shoulder pain and it doesn't matter what they do, it doesn't hurt, then you've got to be thinking that it's unlikely to be the shoulder that's causing the symptoms. It could be a biomechanical issue. There may not be an injury, right? And they can still have pain. We know that with the kind of breakthroughs in pain science over the last sort of 10 years, you can have pain and there's nothing wrong with the tissue. It is a perception. And I mean, that's a whole other webinar that we can do. This is the whole point. It just gets you thinking about other things that it could possibly be, rather than a musculoskeletal problem. So with Liz then, so she had she travels a lot by train, and a few of you picked up on that. And yes, that can lead to biomechanical issues in the hips and the pelvis. It can hi Jess. It can also cause you problems down your legs, and she was having some swelling down the legs. Okay, cool. Yeah, good. Yeah. So Alex has just posted again. There's actually a good section in the DD book I've just seen, which gives you other questions you can ask. Yeah, that's exactly it. So it will help you figure out the next question. That's the problem with these OSCEs, is you really want to ask another question, but they're not real. They're not there. So in real life, you can obviously dig a bit deeper into the issues, but with these, you haven't got any other information. You've just got what's on the sheet. So you have to think worst case scenario with these, and you should, to be fair, with your patients as well. But you take everything into consideration, and you work on likelihoods. And you'll see on the sieve. So if I just share that again, so that's the sieve that we'll use, and there's a clinical impressions box. So what we do after all the information that you have, you come up with your top three. So what do you think is most likely is the problem? What is your number two, and what is your number three? And then based on those, what are you going to do? Okay, so we'll go through that now. So yeah, a couple of things that are picked up by some people as well. So no HRT following hysterectomy, so that put her at risk of osteoporosis. And then we had the swelling in both ankles. That's usually a cardiovascular problem, and something systemic. But it can also be a problem with your liver. You can have swelling in both ankles if you have a liver problem too. Abdomen bloated, and you can have something called ascites, where the abdomen starts to bloat and swell. There's a couple of things. Ascites is ASCITES, so you can have a look at that. And then getting forgetful and mental agility deteriorating. Those things as well are signs of hepatic disorders or liver problems as well. So there was a lot in this case history that was pointing towards a liver issue. So this is what I came up with based on the case history. So the clinical impression down the left-hand side, these are the things that I thought, okay, she's getting problems here, she's getting problems there, she's got these symptoms. These are the things it could be. And this is by no means an exhaustive list. I've said that before. There could be lots of different things that are going on with this person. So what you then have to do is go, right, okay, I think it might be thoracic outlet. But then you need to justify that. So the next bit is figuring out why. Okay, so you then put in, well, it could be thoracic outlet because she's getting tingling in the whole hand. We discussed this on the last session. So if it's in certain fingers, it's usually a specific nerve. Yeah, good, Jess. Yeah, perfect. And if so median nerve of these three, and then ulnar, well, and a little bit of that one, and ulnar nerve, mainly these two. If it's the whole hand, it's usually a blood supply issue. It could be a compression of the whole neural pathway, so affecting both the median and the ulnar nerve. But it's, again, it depends on what the problem is, and we'll have a look at a test in a second to see if we can work out what's what with that. We've got hip and shoulder pathology because of the locations of the symptoms. So it could just be a musculoskeletal problem. And then you would go through the shoulder, right? Okay, is it an SC problem? Is it an AC problem? Is it a rotator cuff problem? And if it's the rotator cuff, which one is it? And then you test all of those. Is it a bursa that's causing the issue? Is it a joint problem from the GH? So there's you then go into your anatomy and figure out exactly what's going on there. Same for the hip as well. So is it the muscles around the hip? Some people mentioned hip flexors. It could have been the rectus femoris attachment. It could have been the glute attachments. It could have been adductors. And there's loads of things it could have been. So and obviously we need to again work on likelihoods. We haven't got 2 hours to assess people. We need to make decisions quite quickly. The liver gallbladder pathology had a lot of whys and justification. So referred shoulder pain, there was no restriction in shoulder joint range. So that kind of raised the question, well, is it the shoulder that's the problem at all? She was tired, had memory loss, confusion, headaches, upper quadrant pain, and was bloated. So there was lots of things that were pointing towards a liver pathology. So that would definitely be on my top 3. Then we've got a hernia, location of the hip and groin symptoms, potentially. It wasn't very clear in the case history that we had, but that could be something that was in there. Cardiovascular disease, angina, we had high blood pressure, we had the headaches, and we've got high aspirin use. And that can lead to gastrointestinal issues as well. Iliac artery intermittent claudication, so breathless on walking, sitting on the train can occlude the arteries going down to the legs. She had leg weakness as well, so there was a few things that pointed out that. Hi Peter, how you doing? Welcome, glad you can make it. We got the risk of osteoporotic fracture as well. Some people picked up on her age, the fact that there was no HRT. She had a road traffic accident as well, and there was no checkup. So that's a bit of a risk. So we've got a few things that, and the pain in the neck as well. So maybe that's been brought about from that road traffic accident because of her osteoporotic risk potentially. Upper motor neuron lesion is anything to do with the brain or the spinal cord. So because of the long-term aspirin use, she's at an increased risk of stroke. And because she's been getting confused, she's been getting headaches, memory loss, forgetful, that moves that up the list as well. So that's quite a worrying combination of symptoms there. It could just be a facet irritation because of the RTA, the traffic accident she had, and the pain on extension. Raynaud's was mentioned by a couple of people. Now, I think I mentioned this on Wednesday. Raynaud's usually affects both hands because it's a systemic problem. So the fact that it was just in one is a little bit confusing. Okay, it could be Raynaud's, but it's less likely. So the other things are more likely, but it's still something that you'd want to get checked out. The accessory nerve supplies the upper trapezius, and it's one of your cranial nerves. So you can check the accessory nerve for an accessory nerve lesion, and that could be linked to the extension pain in the neck as well. Okay, so there's potential of a couple of issues there, and the trapezius symptoms she's been getting. Altered biomechanics due to the road traffic accident. She didn't get checked out. Nobody had a look at her. So we could have had some kind of muscle guarding, which has then caused what we call an antalgic gait. So they start to move differently because of the pain. So that could be a problem as well. And then last one, possibly a sacroiliac joint pathology, which is then referring into the hip or the groin. Okay, so we've got a few things that it could be there. So on the left were the clinical impressions, and again, like I said, not an exhaustive list. You may have come up with others as well, which is great, but then you have to justify why you've chosen those. Okay, and then the next thing you have to do is work out, well, what the heck do I do? So you then have to work out, well, what can I test in the clinic? So with this person in particular, without doing anything, I would have just written a letter to a GP explaining her symptoms and saying I'd really appreciate your thoughts on further assessment. The way that I write my letters, I make it really obvious what I think it is from the symptoms that they've got, without telling the GP how to do their job. Okay, so some GPs are great with it. Some GPs get funny with you telling them what what you want them to do. So I would have definitely said, I've got someone coming in with shoulder pain and upper right quadrant pain, and she's feeling bloated. There's no apparent reason for these symptoms, and that letter should have been enough to get her the correct examination by going to the GP. If none of that was there, if none of that liver, gallbladder problems were, none of those problems were there, then we could have done active, passive, active, resisted ranges of motion. So we could have done those, no problem at all. We could have done part of this. So we could have done an Adson's test, which we'll go through in a second. I'll show you that if you've not seen it before. But also, if the problem wasn't going away, then it's worth thinking about sending them to the GP for an X-ray, because if they've got an additional rib, then that will be picked up on X-ray. I've had a patient that I've had to send for an X-ray because we thought she might have a cervical rib. And then we've got hernia. That's a GP referral for most people, unless you've done those kind of assessments before. Cardiovascular assessment as well, that's needed to be done by the GP. That's linked into this as well. What you would do with this one, the iliac artery, is where the artery splits around about the belly button area is usually an area that can cause a problem if you're cardiovascularly compromised. So you can have something called an abdominal aortic aneurysm. It's usually in men. That's probably why it's not on my list here, because it's usually like sort of 50-year-old men who are stressed, overweight, that kind of thing. And what you can do is a pulse check, where you check the pulse and the radial pulse in the wrist, and you also check the pulse in the femoral pulse in around the hip. And if there is a problem between those 2 points, so the tubes go in from the radial pulse down to the femoral pulse, then there will be a radiofemoral delay. So the pulse should be symmetrical. So when you feel one and you feel the other, it should be the same. If there's a problem anywhere along that pipework, then there will be a delay in the blood flow. And you can pick that up on possibly pick that up by doing a palpation of the arteries. If you found nothing on those, it doesn't mean that they don't have a problem, and I would still send them for a check. If I thought that I needed to test it, then I would definitely send them to be checked out. We've got spondyloarthropathy, so basically a joint problem in the neck, and in this case in the cervicals, or in the spine rather. So we can do a cervical exam, active, passive, active, resisted, all the usual kind of stuff that you would have done before. Osteoporotic fracture risk, that's a GP referral for a DEXA scan. You want to get a real detailed scan of the skeleton. Upper motor neuron lesion, and you can do a full neuro exam and see what the assessment is like there. And you can also do a cranial nerve assessment if there is an upper motor neuron lesion. It's a whole day's course, that even more than that, to be honest. So not going to cover it today. If you want me to do elements of that, pop it in the Facebook group and I can go through some testing. I think usually what I would do is use my other colleagues to demonstrate on, but I'm going to be limited with people to demonstrate things on. So I'll do my best. I'll see if my son doesn't mind being a model for one of them. We've got cervical facet irritation. That's a potential, and we've done that one. Raynaud's, that's a GP referral. Now Raynaud's is a sympathetic nervous system problem. So there is a problem with the sympathetic nervous system and the regulation of blood flow to the extremities. That's what that is. Okay, so it doesn't matter if their blood supply has been cut off here. That won't give you Raynaud's. It's an autonomic nervous system issue. Okay, so that's if you want to have a look at a little bit more about that, then if you get that MSD Pro app, it will go into way more detail. The accessory nerve lesion, that can be picked up by cranial nerve assessment, and then the altered biomechanics through your hip, lumbar spine, thoracic spine assessments, and doing functional tests, whatever they are. We can have a look at the way that person moves to see if there's any altered biomechanics that are obvious after the injury. And then the SIJ pathology as well. We can do some tests for the SI to see whether that's causing any problems too. So hopefully you can see now the flow of how I kind of sort through information. So first thing, get my list. Okay, so I'll go over this. This is what I used to do with my third years when I used to teach at university. So I go, right, okay, this is the case. What can be wrong? So these are the things that can be wrong. This is why, okay, and then this is what we're going to do. And to be fair, what the first question you need to ask, should I even do anything, or should I just refer this person? And this particular case, I wouldn't touch her with a barge pole. She'd be straight out to the GP, getting a check for liver, gallbladder pathology. Okay, so that's what I would do with this one. I asked a couple of you about what's the mechanism for the liver causing pain into the shoulder. And if you have a look up Kerr's sign, I've got this here a sec. Let me just show you this. So this is from Science Direct. If you search up liver pain on Science Direct, then it'll come up with this. And I've just highlighted this here. So occasionally, hepatic enlargement, so enlargement of the liver, causes diaphragmatic irritation, which produces pain that is referred to the ipsilateral, so same side, supraclavicular and shoulder region. Okay, so that's exactly where Our Lady was getting her pain. This referred pain is known as Kerr's sign and is transmitted via the phrenic nerve and is often misdiagnosed. Okay, so that's what we think has been the major problem with Our Lady. Just go back to that. And so if we have a look here, so symptoms in the shoulder are due to irritation of the diaphragm. Okay, so it's not the liver directly that is causing the problem. When the liver enlarges, it pushes up into the diaphragm. Okay, and it's the irritation of the diaphragm that causes the referred pain into the shoulder. All right, so it's not the liver itself, it's the irritation that the on the diaphragm that is caused by the liver. Okay, so if you've not heard it before, there's a nerve called the phrenic nerve, and the way I remember this, bit sad anatomy person that I am, C345, keep the diaphragm alive. Okay, so that's a good way to remember it. So C3, 4, and 5, keep the diaphragm alive. And around the C345 area is the dermatome, so the sensory part of the peripheral nerve that supplies the shoulder and neck. So if we have a look at this, you might have seen these diagrams before. That is C3, 4, and 5. Okay, so let me just show you this. Okay, so this, just get rid of that. And that. Okay, so this is a view of the diaphragm. The ribs have been cut away. Oh, good. You can see my cursor as well. So there's the sternum. Those are the ribs, and this is the diaphragm. This is the nerve supply for the diaphragm. So if I click on that bit there, that's one of the phrenic nerves, and this one here as well. Okay, so you got right and left phrenic nerve, and then that goes down onto, if I can move this, there we go, onto the dome of the diaphragm. So it innervates the diaphragm. Okay, innervates just basically means switches on. So if we move up, just move up here. I feel like the teacher that can't use the overhead projector at school. Okay, so this is the interesting bit. So if we zoom into this, so there's your phrenic nerve, that one there. And if you have a look, it attaches directly into these here. And that there, if you have a look at this selected nerve there, that's the fourth cervical nerve, okay? And then that one up there, that's the third cervical nerve. So the phrenic nerve attaches directly into those nerves that innervate that area of the shoulder. And that's why you get referred pain in the shoulder, okay? So it's all very, very well knowing that it happens, but I think it's more interesting to know why as well. Okay, let's have a look at this. Okay, so that's why the liver causes shoulder problems. Okay, that's why we think it does. This is one of the tests that you can do for thoracic outlet syndrome. So let's say that she didn't have any liver problems, there was no swelling, there was no confusion, she'd just come in with hand going tingly. Okay, so we can do something called Adson's test. This is a study that was done back in the early 90s, I think. Oh no, late 90s, 2001. Yeah, so 2001, there were 48 patients that they tested, and then they also correlated the results of Adson's test, which we'll show you in a sec, with the gold standard testing for thoracic outlet syndrome, okay, to see whether the people actually had the problem. So we're looking at the sensitivity, so being able to rule thoracic outlet out, and then the specificity, being able to rule it in. Okay, so it's not very good at ruling the condition in. Okay, so if you have a positive test, it doesn't necessarily mean that you have thoracic outlet syndrome. It could be a number of other things. But also the sensitivity, it is pretty good at ruling it out. So if you don't have a problem, then you probably don't have thoracic outlet syndrome. And so we'll just have a look at this video. These guys are great.
In this video, we are going to show you the Adson test for thoracic outlet syndrome.
Get our very own assessment.
Okay, so if you haven't heard them before, these guys are physio tutors. They've got loads of stuff on. They've got loads of stuff online on YouTube, and they also do a book as well.
Thoracic outlet syndrome is defined as a neurovascular symptom complex associated with compression of the brachial bundle, which includes the brachial plexus and/or subclavian vessels. This compression may be caused by several anatomical structures in one or more of the following three compartments: the interscalene triangle, the costoclavicular space, or retropectoralis minor space. The Adson test.
Okay, so if we have a look at this, just try and get rid of, it's not going to let me get rid of that. Right, okay. So we've got, we showed you this video the other day. So this is your artery coming up. So it's, you've got your ascending aorta, and then the arch of the aorta, and then it comes off straight away and feeds your neck and then down into your arms. Okay, and as it passes underneath the clavicle, that's called the subclavian artery, because sub is underneath, so underneath your clavicle. That artery and the nerves coming down here as well, they all are in between these muscles here. So we've got the anterior scalene, which these Dutch guys called scalenes, and then a middle scalene there as well. Okay, so we've got anterior and middle scalene, and then that's where the nerve and the artery will pass through. So there's a couple of places where this can get compressed. They can get compressed in the muscles of the neck, and some people mentioned about if you're stressed, then you might use your accessory breathing muscles a bit more, which is true. So there may be some problems with the scalenes. It may be a clavicular problem. So if you're in a very military posture, then the clavicle will sit back onto the top of the rib cage, and it will squeeze down that space, and it will block your artery and also squash your nerves. So that can give you thoracic outlet as well. Okay, and then you can also have a problem underneath the pec minor. You can't quite see it on this, but you will in a sec. So where the artery and the nerves go underneath the pec minor, you can get a problem there as well. Okay, so there's three main areas where you will have an occlusion, if you like, so a blockage or a squashing of the neurovascular bundle, so the nerves or the blood supply. Okay, so let's have a look.
The test is designed to decrease the space in the interscalene triangle. According to Gila et al. In the year 2001, it has a sensitivity of 79% and a specificity of 76%.
Now, when I looked at the paper, it didn't say those figures. Okay, so I'm not sure whether they've got the figures right there, but you can have a check of that. Yeah, definitely. Yeah. So Al's just said common in females aged 20 to 50. Yeah, the majority of people I've seen it with are bodybuilders. And if it's a normal person who doesn't do any kind of extreme sports or anything, then it is usually females rather than males. But for some reason it's more common with them.
Regarding the rather low accuracy values, and due to the fact that the study did not make use of MRI as the gold standard, the clinical value of this test is rather weak. To perform the Edson test, have the patient in upright sitting position with his arms remaining supported in his lap. Then the patient rotates and extends his neck to the tested side. This is followed by...
Okay, so the reason why they're getting the head into that position to test it, you want to bring the head back and then into rotation, because you want to try and trap the blood supply or the nerves going through the scalenes. So if you have your head in extension and then a rotation to that side, you will contract those muscles and it will close up that space. Okay, so what we're trying to do is reproduce their symptoms. Okay, so if we can reproduce their symptoms by putting them in this position, then we have got a better idea about what kind of treatment that we need to do.
By a deep inspirational breath, which is held for up to 30 seconds, as the examiner palpates for any changes in the radial pulse. Modification.
Okay, now the reason why you have your head in that position and then you take a deep breath in, as you breathe in, your rib cage will rise, and because you're depressing the shoulder and keeping the shoulder down, the rib cage will come up into the clavicle, so it will close up that rib cage and clavicle space. So if the blood supply coming through that area is already occluded, then that is going to squash it even more. So when you feel the pulse, when you feel the radial pulse, if it's a vascular problem, which we think it is with Liz in this case, then the blood supply will drop off. Okay, so you feel a radial pulse and it will be normal, kind of bounding. And then as they bring the head into that position, take a deep breath in. If it squashes anywhere, then the pulse will drop off. Okay, so and it's really obvious as well when it happens. There's been a few people on our courses where we've done it, and their hands have gone numb straight away. So they don't have the symptoms day to day, but they've been positive for the test. So it's been really interesting. Even if you haven't got the symptoms, sometimes you can fail this test.
Patient is described with the shoulder in 15 degrees of abduction and the head maintained in the testing position for 1 minute while the subject breathes normally. This test is positive in case the radial pulse is abolished or if the patient's familiar symptoms are reproduced.
Okay, so that is a test you can do for thoracic outlet syndrome called Adson's test. As they said, it's got weak clinical value. We would like the test to be up in the 80% if it was going to be a good one. But to be honest with you, unless you're doing one of these ultrasound, some kind of MRI, then we wouldn't or X-ray for a cervical rib, we wouldn't actually know. Okay, so we're limited with what we have in clinic, and this is one of the best tests that we have at our disposal to be able to figure out whether that person has potentially got thoracic outlet syndrome. Okay, so it's not a great test, it's not the best test, but it's the only one that we have. Okay, cool. So next Monday, we've got a new OSCE, and I'll be preparing that over the weekend. So it'll be 6 o'clock again on Monday. If you need any more information about what we've done over the last few sessions, or about anything else that we do as well, then please feel free to message me on the Facebook group or drop me an email as well. That's my email address there. Hope you enjoyed the week. It's been really good for me to focus on something, and we'll see you next week. Cheers, guys.